Good morning, everyone. It's my pleasure to introduce our speaker of today, Dr. Roy Strowd. Dr. Strowd is a professor of neurology and neuro-oncology and interim chair of neurology at the Wake Forest University School of Medicine. Dr. Strowd received his a degree in religious studies from Duke University and his medical degree from the Wake Forest University School of Medicine. He completed his residency at Wake Forest and his neuro-oncology and education research fellowships at the Johns Hopkins University School of Medicine. He also earned a Master of Education in Health Professions from Johns Hopkins School of Education and a Master of Science from the Wake Forest University Graduate School of Arts and Science. Dr. Strowd is a board-certified neurologist specializing in neuro-oncology. As an educator, his mission is to inspire each student to find their passion and pursue it. He's chair of the e-learning subcommittee from the American Academy of Neurology and is the current editor for Neurology's newest journal, Neurology Education, which publishes original research articles in health profession education. As a researcher, his background in neuroscience provides a neurocentric approach to neuro-oncology and translational research. His research is advancing the field of neuro-oncology by discovering new treatments for glioma and innovations to improve the quality of life for patients with brain cancer or inherited tumor syndromes. He's chair of the chemotherapy-induced peripheral neuropathy investigator team at Wake Forest and co-directs the tuberous sclerosis and neurofibromatosis multidisciplinary clinics. He's active in the Comprehensive Cancer Center and serves as co-program leader for the Experimental Therapeutics and Applied Sciences program, overseeing the conduct of early drug studies across the Cancer Center. He's published over 140 peer-reviewed articles as author of Neuro-Oncology for the Clinical Neurologist and has served as national principal investigator for multi-site studies through the Adult Brain Tumor Consortium and the ECOG-ICRN cancer research groups. His time away from work is spent trying to keep pace with his three kids, and if not then playing soccer, brewing beer, and or snow skiing. Please join me in welcoming Dr. Strowd.
Well, thank you. It's great to be here. I am sorry for the technical difficulties, and Alexandra, kind of help me as we go through in case we run into some additional technical problems. I've done a lot of things, and technology is clearly not one of those. So I've struggled this morning. We're doing some home renovation, and it's spring break. So I happen to be at home, and that's the one time, the internet just decides to stop working. So glad we got it to work. I hope we can get this to continue throughout the portion of the talk. I'm really excited to be here. I'd love to come back and talk a little bit about neuro-oncology in the future, but today is education and kind of an education-centric day. I usually like to make this pretty interactive. It is the best way to teach. And so if we're going to talk about teaching, we might as well model it and example it. And so we'll try and find some ways to do that as we go through. And some of this may be sort of on your own. We may try and get a little bit of engagement through the Q&A, as we go through. We're going to talk about teaching, from teaching to scholarship. What are some of those things that you are seeing if you're a resident or a student or a fellow? What are some of the things you're doing if you're a faculty or a resident or fellow, interested in education? What are those education ideas? And how could those be shaped into scholarship? And we'll kind of talk about that over the course of the next, 40 minutes or something like that. It's good to see some friends. I see some friends in the audience, Ashish and Andres and others. So, thanks for being here. I was asked to put this slide in at the end, and it always is tough to get there at the end. So I put it in at the beginning too. So if you want to see me credit and your GW, here's the way to do that. There's also a slide of this at the end. Here are my disclosures. There are no disclosures particularly relevant to this talk, except I do receive an editorial stipend as a part of being editor of Neurology Education. And most of what I'll talk about today is from Neurology Education. There are other journals that publish education manuscripts in neurology, but this is one I spend a lot of time on. So I'm going to talk about that one and some of the work that we've published there. And this is the breakdown. We'll start sort of a 3-section talk. We'll start with the journal. And for those unfamiliar with it, I just want to make sure we're all on the same page. What is neurology education and what's happening in neurology education? We'll focus on one article. I want to dive into this article, and that's where we'll try and get a little bit of engagement to get your sense of this. And then I hope to end with 5 tips for taking your teaching work or your observations in education and bringing them into the literature. How do you get involved in this? And we'll try and end with these 5 tips. Alexandra, is the internet working okay? Are you hearing me okay?
Yes.
Okay, great, thanks. All right, so a little bit about neurology education, and then I'm happy to take any questions about the journal. There'll be a brief time to do that if you have a question about the journal, but I want everyone to know about it. So neurology education is one of the latest of the neurology family of journals. The newest is actually Neurology Open Access. So if you haven't heard about that one, take a look at Neurology Open Access. Neurology education launched about 3.5 years ago. It's a peer-reviewed journal in the field of neurology education. So it's not teaching about neurology. It's meta. It's teaching about how to teach neurology, education research. What are the right ways to do education? What is the evidence basis for that? Is where that fits. We publish original research articles. About 3/4 of the articles are original research, as well as reviews. If you're earlier on in your career, you haven't yet done a project but want to get involved in scholarly conversations, a review article, a methods paper, a history paper about how did we get to where we are in training can be a good way to get involved. And then editorials and viewpoints on really hot and important topics in the field of education in the clinical neurosciences. The journal also seeks to provide a mechanism for exchange of ideas. You can see at the end of this to enhance teaching in neurology and clinical neuroscience. And I'll talk about a few of those that may be particularly attractive for getting involved in scholarly discourse in the field. Some people like to know just the nuts and bolts of the journal, and here are some of those kind of key data or numbers. We're data people. So we have a 40% acceptance rate right now, which is probably where the journal will live. There's just a lot of good teaching work that is helpful to share and disseminate. And so that's where the journal has been for the last few years, which is better than some other kind of biomedical journals where the acceptance rate may be sort of 10, 12% or something like that. 31 days to first decision. We like to get reviews turned around fairly quickly. So all right, never a dull moment at home on spring break. That's my dog, Hank. He says hi too, apparently. So 31 days to first decision and 30% acceptance from reviewers. So we've got a really rich reviewer pool if you're interested in getting involved in education research, and those sorts of things. We'd love for you to email the journal, nejneurology at neurology.org, and be a reviewer. We typically look for 2 to 3 reviewers for each article, and we often like one of those to be a trainee. If it's a student manuscript or a manuscript about an intervention for residents or fellows, we like to get that perspective. And so wherever you are in training, there's an opportunity to get involved. And then this I'm really excited about. I think a lot of our editorial board members are excited about this. This is the newest submission type for the journal called the Curriculum Resource Report. So most of what the journal publishes are research manuscripts about an intervention, an education intervention where there are outcome metrics and data that really speak to the broader theories in education. But a lot of the work that educators are doing are actually to teach and to develop curricula that respond to the local needs of of learners in their area. And this is an outlet for that work. So this is a mechanism of publishing, of disseminating the actual curricula. So the slides that help to teach how to review an MRI of the brain, or the debrief guide and the checklist and the cases for a simulation course or series or workshop or something like that. So similar to like MedEd Portal, this is a mechanism for publishing the actual curricula and disseminating those to other educators. It's great if you're an education chief and you need to teach about, say, a simulation course on equity in neurology and clinical neurology, because you can download all the tools that someone else has developed, implement them in your area. And these are intended to be an off-the-shelf mechanism of teaching quickly and not reinventing the wheel at every institution. So this is one of the first neuroscience-specific outlets for peer-reviewed dissemination of curricula. And there are a few examples here. So the first one was from Jordan Newman at University of Michigan with this group. And they published or disseminated this Foundations of MRI of the Brain for neurology clerkship students. So when you're on the clerkship, and you have a number of students rounding on the stroke service or general neurology service, we often teach about the MRI scan. And this is an asynchronous go on your own PowerPoint that students can review to understand, well, what is the T1 and what does ADC mean? And where does the DWI come from, and can understand how the MRI works and how those images are created, so that then on the wards, you're teaching about the clinical medicine that's visible on the MRI and not just the fundamentals. We've published a few simulation curricula. You can see here one teaching equity skills for neurology residents. So this may be an ideal mechanism of dissemination if you're an educator, if you're an education chief, if you're developing those resources and you found them to be beneficial at your institution, a good way to disseminate them to others. And then the last part is we're always looking to develop the next generation of peer reviewers and editors. We have a very robust editorial internship program. This is a one-year internship with the journal. So if you're a senior resident or a junior resident or a fellow, this is for senior residents and fellows. And they spend 1 year with a journal just understanding, how does a journal work and how do you review and what is the editorial process? So we've been running this for 4 years. We get a number of applications over the course of each year. The call goes out in July. So we'd love to see your application if this is something you're interested in. And you can see our current list of just really phenomenal residents and fellows who are interested in the editorial process. And we've seen GW there. So I love this GW Grand Round series. You all do a number of really innovative Grand Rounds, and wanted to call this out. This is an article by Mia Minin. She's one of the faculty at NYU, very interested, really a seasoned expert in getting neurology down into the pre-medical school group. So this was an article on bridging the undergraduate neurosciences with clinical neurology, bringing clinical neurologists into colleges and universities to pique interest in clinical neurology early, and a call out to another GW Grand Round series, the Epilepsy Center Grand Round series, which has been doing some innovative things at connecting guest speakers remotely, bringing people together virtually. And so would love to see, your all's work. You all are clearly influencing some of those conversations, and would love to see that work disseminated, in the field and maybe even in the journal. So that's a little bit about the journal. I'm going to pause, see if there's any questions about the journal. Sometimes there are, often there are not, but if you want to put them in the Q&A, happy to answer any questions about the journal, how to get involved in the journal, what we publish in the journal, those sorts of things. And I'll pause for a second to see if there's any questions. And often there's not.
See any in the Q&A, yeah.
Okay. Well, and I'm going to flip to one article. There will be some opportunities to ask questions as we go. And I may try and see if we can get some engagement through the Q&A. It's always a little bit difficult this way. So if you want to use the Q&A, I can't see it, but Alexander, maybe you can. And for folks who are joining, yeah, if you want to answer this question, and if you can answer it in the Q&A, I'd love to know your answers. But, we've got a lot of people on, a lot of clinical neurologists. So if you could temporarily turn off one responsibility today for an hour, what would you turn off? Secure chat, in-basket messages, code stroke alerts. What would you choose? And if you can, put it into the Q&A. Alexander, I don't know if you can see it or if we can read them out as they go.
Yes, of course. Stroke alert, someone responded.
Okay.
In-basket messages from someone else.
Absolutely.
In-basket.
In-basket. In-basket. That's right. Right? Like the dreaded in-basket. Right? Yes, this is a running theme now. Dr. Galati. Love to see it in basket messages. So common
Basket as
theme,
well.
right? So
Yes.
absolutely. So I don't know. I mean, there's a lot of things that fly at us, and we'll come back to this because I think you're right. It is those in-basket messages that are just flooding our area. I was about to log on to this and I got a secure chat right before this of, a medication that needs to be refilled and these sorts of things. So all throughout the day, we're sort of bombarded with a few of these. So we may come back to this, hold that thought, sort of, keep that in your mind. So one other question, and maybe you'll share these in the chat. What are the hacks, right? You all know these. What are the pro tips that you do to balance those work responsibilities? When you're inpatient, you're getting the in-basket messages. How do you manage those when you're seeing a patient and the code stroke comes in and do you have to go? Do you not have to go? Are you covering? Are you not covering? Or the in-basket messages are coming in or you get a secure chat? So what are those ways that you balance work responsibilities as you're navigating your clinical activities during the day? Any tips? How do you do this?
While we wait for some answers in the Q&A, from my end, that would be like quick triaging of that message. Is it urgent or can be dealt with later?
I love the triage mindset, right? Is you've got to do this. There are some things that the code stroke, you're going to pause and go do that, right? So that is top priority, but other things you're not.
Yeah.
Olga, great comment in the Q&A, right? There's a way to put yourself as unavailable. So in some of these areas, you can sort of indicate and designate sort of, are you available? Are you not? How does someone reach out to you if there's something urgent to do? So, and then you can check those in between patient-facing activities. That's great for inpatient, right? Is when you're on rounds, you're unavailable, you come off rounds, click yourself back to available. So that's a good efficiency mechanism. Helps to kind of divide your time. Multitasking, Carlos, I love it. You're just like grinding through. Like I'm just going to do it and find a way to kind of multitask. I'd love to know maybe how you multitask. What are some of the ways that you found that to work? And triage is important. It's critically important. And we could even dive into that a little bit further. How do you triage? And how do you know what's important? How do you quickly assess a message that's coming in and sort of where do you put it on your list of this is something I need to address now or maybe later? Chat messages are not meant to be used for emergent or urgent matters. So that's a great, right? The goal is to have different mechanisms of communication so that just by the way it's being communicated how important it is. A long time ago, that's what text messages were for, more urgent things. But now you get text messages for everything and emails that you need to address within the hour or, those sorts of things. So sometimes we don't always follow those typical communication norms. And so it can be a way of triaging, but we've got to be careful because sometimes folks may use a means of communication that's a little bit different from what we've expected. So we've got to have our alert signals on. Andres used the Eisenhower matrix to decide what to tackle. All right, so we'll have to dive in the Q&A on this matrix and learn from you, Andres, a little bit more. I love this is sort of using some tools to as a decision tree for how to triage things. Well, we're going to keep this in our minds as well. So I want to dive into an article. But I want you to keep this sort of sense of how over the course of your day do you balance the responsibilities in front of you, and how do we as educators and as an education system create a way for that to happen? Because ultimately, if you can focus on the patient in front of you, you're going to do a better job for the patient. The patient's probably going to get a higher quality of care and will probably keep us all sane and help our work to be meaningful. And so this may be a question we'll come back to as we end this paper. But I want to dive into a paper that discusses some of these things. This was one of the early publications in neurology education, the effect of an X+Y schedule model on neurology residency training. This was from the UCLA group, Adrian Keener, Charles Flippen, and the group at UCLA. And I don't actually know if GW uses an X plus Y schedule. Alexandra, do you all do X plus Y? No.
No,
So this
not
will be an
currently.
Yeah, so this will be an interesting conversation. We don't use X plus Y at Wake, and so we'll kind of talk through this. And the goal isn't for every residency to adopt this, but there's probably some things we can learn about residency training broadly from this paper. And as we're walking through this, one way to think about this is how to take a project that you're doing, an observation or an educational challenge you're solving at GW, and how to enter into a conversation that's relevant for other educators across the nation. So this group in the introduction sort of writes the problem that they're solving. 90% of neurology residents indicate that they will do a fellowship. And many of you know this. This starts not as a PGY 3 or 4, right? As a 2. You're having to figure out, what am I going to be doing with my future? Am I going to be doing a fellowship? And now more than 90% of neurology residents indicate that they'll do a fellowship. Fellowship applications really occur very early. Often it's difficult to have had enough outpatient exposure. I see this in neuro-oncology. The 3s and the 4s are coming through my clinic, but many of them have already had to indicate what fellowship they're doing. So we need more outpatient exposure early in training to ensure that trainees really get exposed to all of those areas of ambulatory neurology. And adding outpatient clinics during inpatient service adds stress and burnout to residents. So these are some of the challenges that exist in our field that this group was trying to address with this intervention. They looked around and saw that in other fields, internal medicine and pediatrics in particular, an X plus Y scheduling model has been feasible and implemented to increase outpatient exposure early in residency as a PGY2, in some places as a PGY1, to get more outpatient time. And we'll talk about what an X plus Y scheduling model is if you're not familiar with it. And what wasn't clear at this time, back in 2022, was neurology is very different from internal medicine and pediatrics. We have smaller residency programs. Our residents are expected to cover different services in different ways. And so the gap that this group sought to address is, can an X plus Y scheduling model be feasibly implemented into a neurology residency program where there are different nuances than these others, and will this improve the resident experience? So this is what they did, and we'll have a few slides just on the intervention. So this is their PGY2 schedule at that time at UCLA, and you're looking at the 8 adult residents, 2 pediatric residents, and the PGY2 year on this figure over the course of 12 months. All the gray blocks, all the gray squares are primarily inpatient weeks where the residents are pulled out to continuity clinic. Sounds like that's what it's like for you. That's what it's like for our residents at Wake. And then there are selected ambulatory only blocks. Those are the green blocks. So that was the pre-intervention. They looked at the number of outcomes before they intervened. And the intervention was this. So this is now looking at half of the year, because each of these blocks are now 2 weeks. And they looked at a 4+2 model. So that means 4 inpatient only weeks where there's no continuity clinic, no outpatient expectations, no outpatient responsibilities, followed by 2 ambulatory only blocks where residents are rotating through ambulatory clinics in neurology. They're not on inpatient service. They're not covering any of the inpatient activities. And so they're able to divide their time. And so you can see more green, right? Over the half of the year for resident 1, there's 2 inpatient weeks in the county inpatient, 2 inpatient weeks in the VA, and then ambulatory 3 is the ambulatory clinic. And this is what that ambulatory week looks like. So residents are able to be scheduled into some really diverse subspecialty areas in neurology, neuro-otology, neurogenetics, neurobehavior, headache, as well as a number of continuity clinics that they're doing in these 2-week ambulatory blocks, the RCC, or resident continuity time. And they wanted to see what was the impact for residents, what was the impact for the training program, and what was the impact for the resident experience as a result of this intervention. So what did they find? Well, here's some of the results. So first, they saw that there was an increase in outpatient exposure. The traditional model, there was 44 weeks of inpatient time where residents are pulled out to do continuity clinic and 4 weeks of outpatient elective. And in the X plus Y model, there's just more outpatient weeks, 15 weeks of outpatient clinic. And that's not surprising you saw that. That's just a result of the structure of the X plus Y model. There was an increase in continuity clinics because there were these dedicated blocks. Residents were able to do more continuity clinics, so 43 continuity clinics over the course of the year. And ultimately, some of the administrators and service line folks and the chairs and those sorts of people, are always pleased with that. An additional 145 patient appointment slots were able to be opened. And that's valuable just for residents. They're seeing 154 more kind of new undifferentiated or those sorts of patients that they're able to be exposed to as a PGY2 early in their career. There were less handoffs, 1,800 before the intervention, 1,500 afterwards. So that's important for the system. Handoffs are potential at-risk near-miss events, so a reduction in the number of handoffs as a result of residents not rotating through and kind of handing off patient care as much. And important for residents, no increase in work hours, right? So the residents are working the same amount of time. It's just a shift in where residents are working over the course of their PGY2 year. What did learners think about the clinic? So they looked at what learners thought about the clinic and what they thought about the inpatient services. And they did so with a satisfaction scale and survey to the PGY2 residents participating in this. Red is dissatisfied, the dark blue is satisfied. So preparation for outpatient clinical practice improved, and they saw residents were much more satisfied with their ability to prepare for clinic because you're going into clinic those weeks. You know what you're going to be doing. You can prepare for the neurootology clinic or the neurobehavior clinic or those sorts of things, both for the patient care as well as the learning that's going to happen in that space. The ability to follow a condition improved. So our interns here do this in my clinic, and they rotate once a month with me. I'm in neuro-oncology. I see most of my patients once a month. So a lot of the residents and interns will end up seeing the same patient 3 or 4 months in a row and are able to really follow the longitudinal decisions that we're making with that patient, as opposed to get one snapshot in time and not really be able to see and understand how the decision in one clinic influences the experience in the next. And then the ability to focus on responsibilities. That gets back to that in-basket messages and secure chats and those sorts of things improved dramatically. Residents in the pre-intervention were balancing inpatient and outpatient. They're doing discharge summaries in between patients that they're seeing in their continuity clinic and answering my chart messages and in-basket messages when they're on rounds, right? So the ability to focus improved in the clinic. What did learners think about the inpatient wards? So this was the response to the experience inpatient. And again, this is kind of an outpatient intervention, but there was improvement in how residents experienced the inpatient wards. So the amount of time I had to learn on the inpatient service improved. The time I can spend with patients during inpatient service improved, right? The residents are able to dedicate time in the inpatient services to the patients that are on the service and not be dividing their time. And the ability to focus on responsibilities during inpatient service also improved. And then what about kind of fatigue, stress, well-being? They were also interested in looking at the impact of this intervention on those aspects of just being a busy PGY2. If you're a resident, you're feeling that, or you remember it. If you're a faculty, it's sort of etched in your mind. It's a really busy year juggling and balancing, those things in front of you. And what they found is that residents reported less stress during their clinic, during their ambulatory clinic, improved fatigue, less fatigue, and more personal reward being in the clinic. So as a result of being able to dedicate time, in the clinic, there was more personal reward during that time. And they actually saw the same thing reported about the inpatient service. So less stress in the inpatient service, less fatigue during the inpatient service, and more personal reward from working, on the inpatient service. And as we think about the purpose of that PGY2 year, which is both patient care, learning patient care, but also being exposed to the many areas of neurology, that personal reward ends up being a big driver in trainees getting excited about pursuing a career in neurology, and particularly a career in ambulatory or outpatient neurology. So the authors concluded that the 4+2 X plus Y scheduling model for this residency program was feasible, right? That's what they were looking to explore. It increased clinic ambulatory time, increased satisfaction, I didn't show right scores, but it did improve right scores, or they found improved right scores for selected outpatient topics that were covered during those green outpatient weeks. Reduced handoffs did not change work hours and enhanced well-being. So what made this article a must read, right? Why do I present it here? GW isn't doing an X plus Y model. Wake isn't doing an X plus Y model. Why is this relevant for other educators and readers to read? Well, in the discussion, these authors kind of go back to this concept, and I think we can pull this concept into the discussion here. This is a pager for those who maybe are currently in training. I don't carry a pager anymore. Our residents don't carry pagers. I'm not sure if you do. It's all through the phone these days. But that's where we started, right? Residency is all about juggling and triaging and balancing. And oftentimes it's the my chart in basket messages or the secure chats that's really dividing us in our ability to kind of focus on the patient in front of us, the task in front of us, the learning in front of us, the clinical care in front of us, and those sorts of things. And so the authors really draw on this concept of psychological safety as being one of the kind of underpinning principles that they're studying and seeing in these data. So clinical medicine is high accountability. So we're often in either that learning or anxiety zone. And one of the things that helps move us as trainees or educators or clinical practitioners from that anxiety, that high stress, struggling to triage all the things in front of us, that anxiety zone, into the learning, or so what some people call the performing zone, is psychological safety, the ability to create a space where you've got the time, the bandwidth, where you can focus on kind of what's in front of you. And this intervention was an X plus Y model, but may have really been an intervention to enhance psychological safety as a resident, as a PGY2, rotating through inpatient and outpatient services, and to create spaces where residents were more able to be in a psychologically safe space and focus on the inpatient or the outpatient in front of them and the duties and tasks and learning that help them to perform. So kind of drawing on this concept of psychological safety. So going back to where you started, and we'll see if I can pull up the chat again, or the Q&A again. So thinking about this, what are the things you currently do that help enhance psychological safety in your program, in your part of training, in your space? As you think about those triage mechanisms or the efficiency things that you do, what are the things that you see that enhance psychological safety where you are? And if you put them into the Q&A, let's read them out. It'd be great to learn from your perspective. How do you do this? How do you balance the demands in front of you and enhance psychological safety in your program? Alexandra, I don't know if you have any thoughts as we see what people think about this.
I think probably just open communication to be, available for each other, just discussing issues that come up is the first thing that's coming to mind.
So this is a great comment. I'm sorry to put you on the spot, but appreciate you sharing thoughts. So you're right? How a residency program is structured, those kind of relationships you're building with other residents can be very helpful. You've got to go down for the code stroke, but you still need to keep rounding, and who to connect with or who to talk with, to sort of hand off some of that. And there's that trust, right, from resident to resident, or there's the group chat, right? That's a simple mechanism to help enhance communication. And it seems so simple. It's just a group chat. Don't we use those all the time? But that's actually creating the mechanism so you don't feel like you're pulling someone into something that they didn't want or didn't expect or didn't need to do for their work. But you're just asking for a hand, right? And there's a mechanism to do that. Carlos, attention to good sleep, right? This is a great point, right? So sleep's critically important. And there are systematic and program level ways to sort of help to support things like sleep, eating, right? Sometimes we provide food at grand rounds when it's in person or at our, resident meeting or something like that. So that's supporting all the things you've got to do as a resident to sort of show up and perform. Yeah, be thinking about this. What are some of the other system things, system interventions, or the ways your system is structured that help you to triage, that help you to call out for help, that help you to focus on the outpatient that you're seeing if you're covering the inpatient wards, or that help you to get through rounds and not kind of get barraged with other things. Are there ways for your program that you'd like to see that done? Or are there ways to tweak or change or kind of put some of these mechanisms in place? It may not have to be that X plus Y model, right? We haven't gone to that at Wake, but in looking at this paper, we have thought about some of the ways to create that. So for our academic half day, we have an academic halfway. The residents, they drop their pagers off in a bucket as they walk into that room, and the program director sits that and answers pages over the course of the afternoon. And that's been a neat way. It's not just giving up work to go learn. The program director actually starts to understand what types of pages the residents get over the course of an afternoon. And that's helped us to think about, well, how could we work with our nurses on the inpatient service? How could we work with our consultants to improve the quality of pages that come in, or to help them think about the timing of when they're paging residents for kind of urgent or non-urgent things and those sorts of things. So that's actually been a helpful mechanism. Our team has reviewed some of those pages as they've come in and sort of found a way to provide some feedback into the system. So if you have other thoughts, put them into the Q&A. This is a good time to be thinking about your program and how you may want to sort of enhance this aspect of your training. Carlos, thanks for your comment. Alexandra, thanks for your comment. All right, and then now I'm going to move to the 5 tips, and we'll cover quickly 5 tips for taking your education, your educational ideas, a program you may be working on, and turning it into education scholarship, and then we'll end with just some general Q&A that you may have about neurology education. And I'll go pretty quickly through these, and then if you'd like for me to dive into any of these in any more detail, we can. These are 5 quick tips for taking an education project or an education idea and turning it into a publication or some type of scholarly unit. Hank. So tip 1, if it's an innovation, make sure it is innovative. And there's a great paper by William Zimmerman and a group, again, published in Neurology Education, that was a scoping review of innovations, curriculum innovations, and taking a published set of criteria, sort of a standardized list of what makes a curriculum an innovation, and looking at the neurology education literature. And there's a few things that they learned from that I think are really helpful if you're an educator thinking about publishing in the field. So the first is, this is a trend of published manuscripts in neurology education, not the journal, but the field over the last 10 years. And the lines are going up. So all innovation studies, there's just an increase in the number of published innovative curricula over time. So it's harder to publish those things in the field. There's a lot of simulation studies. That's the dark blue, the next line. There's a decent number of e-learning studies, and sort of a trend in 2021. We've seen this continue since 2021 of those e-learning, online learning, asynchronous learning, social media learning, those sorts of things in the aftermath of the pandemic. So there's more curricula that are being published as innovations in the field. This is those list of 12 criteria that were put together by a team published in Academic Medicine. I think it's a really nice list, sort of a checklist of what to include in a curriculum innovation publication, and the frequency that authors include these. And ideally, all of these would be 100%. This is what should be published in a curriculum innovation manuscript. You'd like to see most manuscripts including these, and some of them are included. So a description of the problem, that's good. It's important. It seems like that should be 100% and maybe not 99%, but all curriculum innovation should describe the problem, describe the innovation and how it was implemented, so the implementation. If it's a novel grand round series hosted virtually to expand the reach of clinical neuroscience, right? How was that implemented? When was the virtual series hosted? How was the invitation or the marketing or those sorts of things done? How was the technological challenges overcome, right? How was it implemented? It should describe the development of the innovation, and often describe the iterative approaches to developing and refining it to include data an outcomes and evaluation method of the innovation, and a rationale. And most published articles include that. What's really interesting is up at the top. So only 46% of articles discuss sustainability over time, how that innovation was sustained. Very few actually explain what was novel, what was new, or how it was specifically innovative. So how is this different from something that has already been done? And include specific examples that explain why that's the case. And very few discuss the potential transferability. Many of these papers, 61%, are describing how this was, or actually 49%, how this was done at their institution, but not how this could be transferred for others. So if you are publishing an innovation, discuss the sustainability, explain specifically what was novel, new, or innovative, discuss transferability. How will this be transferred to another educator's educational context? And that's a way of taking that idea and project that you're doing and really making it attractive to other educators, readers, and ultimately the reviewers that are going to review the paper. So discuss sustainability, explain what's new and novel, discuss transferability. These are ways to get that idea published. And here's an example of this. This was from a group at Harvard, a great paper. I really love this paper. It was about a novel way to do a noon conference series. This group took 6 noon conferences over the course of a single academic year and focused it around storytelling. They invited a patient and a physician, the neurologist, and a resident, and the resident interviewed the patient and the neurologist, not to discuss the diagnosis, what was this disease, or what was the exam, or how was it diagnosed, but to discuss the longitudinal management of that patient over time. So really to get into shared decision making and therapeutic decision making and longitudinal decision making. The pilot program was about TBI, ALS, Parkinson's, epilepsy, dystonia, and migraine. So that was the 6 patients they selected. And in the paper, they talk about that they learned that those were not great conditions to discuss longitudinal management. And so where they ended with the final program was muscular dystrophy, where now there are a number of gene-based therapies, and how do you pick the right one, and how do you assess response for the patient over time? Migraine and MS, where there's tons of medications now, and it really lent itself to discussing, well, what if first-line treatment doesn't work, and how do you decide second-line treatment and those sorts of things? Alzheimer's, epilepsy, and functional neurologic disorders. And so the tip here is that presenting not just the first pilot program, but publishing on the final program and describing that iteration was really what made the discussion of a patient-centered noon conference, which is not that innovative, actually a really compelling curriculum innovation. So number 1, if it's an innovation, show and explain why it's innovative. Number 2 tip, if you are publishing a curriculum, show high-order outcomes. This is Kirkpatrick's model here that you can see of how to think about outcome assessment of a curriculum. And it's good, it's nice, because it's simple and it makes sense. And so the way I look at this model is most curricula, pretty much all curricula, should have some type of level 1 outcome metric, and that's assessing learner reactions. And that's not just satisfaction or would you recommend this course as is listed in the example, but you want to assess how the learners reacted to the actual course. So if it's a virtual Grand Round series that's using a webinar format, ask the learners about the webinar format. Ask them about how the Q&A was used. Ask them about how the chat function was used and how did they react to that? How did it engage them or not engage them? Or what were the ways in which that worked? So it's really how the learner reacted to the specifics of the educational intervention. And those are sort of higher quality level 1 outcomes. Level 2 is learning. So all curricula should assess some type of knowledge, skill, or attitude acquisition. That makes sense. We should assess that. But the really high quality education work and innovative curricula usually reach into a level 3 or level 4 outcome. So what was the impact on behavior? Did learner behavior change? Were residents prescribing different things, or were they ordering different things, or were they approaching rounds differently, or did they see their patients in a different way, or did they go to clinic differently? So did behavior actually change? Self-reported behavior is one thing, but observer-assessed behavior is much better. And then level 4 is results on the system. So what was the impact on the patient care? What was the impact on the clinic? What was the impact on the health system or the residency program? That X+Y model measured handoffs. It measured duty hours, right? So those are system level outcomes that are really attractive. So Kirkpatrick's model can be a great way to do that. Here's an example of this, and this actually only assessed level 1 and level 2 outcomes, but they did it in a really nuanced way, I think, that made it attractive to readers. So for the ophthalmologist in the group, this is for you. This is a curriculum innovation targeted at teaching residents direct ophthalmoscopy. We just saw a patient in the resident clinic here presented with headache, and this is the number one thing to evaluate for a headache patient, and we were talking about the ability to teach this for residents. So it's been a tried and true, but a key part of residency training for decades, for centuries, and still is important. So this group looked at a novel or an innovative way to teach this in their residency program, and this is what they assessed. So first, performance of the ocular exam components before and after the rotation. So were residents able to administer dilating drops, conduct direct ophthalmoscopy on dilated and undilated pupils before and after the intervention? Then they looked at confidence. So we're always going to look at confidence, confidence in focusing on the retina, finding the optic disc, finding the retinal blood vessels, and recognizing optic disc pathology. So they looked at each of the parts of the curriculum that they were teaching, not just that overall confidence in the exam or the skill or the patient, but on each of the individual aspects, which were their learning objectives, which made it a higher quality confidence assessment. Then they looked at satisfaction. So they did assess that level 1 satisfaction with each of the core learning objectives that they set for the course. How satisfied are you with the current level of direct ophthalmoscopy, of examining a patient with ocular or visual concerns, and how likely are you to incorporate this into your practice? So, sort of moderate or, a mechanism evaluating resident satisfaction. And then they looked at an objective assessment, so an OSCE-based assessment of the techniques that they taught. So the techniques in each of the sites that they studied before and after the rotation, and the scores on this objective ability to perform those, the technique, fundus visualization, and the total score. So this is a fairly nuanced way of evaluating level 1 and level 2 outcomes of something we do all the time, and every residency program is looking to teach. And so a good example of how to use this model to evaluate a curriculum and move it from a single institution individual intervention to something that is publishable and can influence conversations broadly. Tip number 3, be rigorous. So these are studies, so get IRB oversight, and many educational interventions are expedited or even exempted from IRB review, but all of them should be reviewed by the IRB. If you're submitting for publication, you are often studying human subjects. That's often what we do in education and contributing to generalizable knowledge, and so those should be overseen by the IRB in some way. Be careful. If you teach someone something, they're probably going to learn. That's why we teach. And that's not new or novel, but that's a lot of what we do. A lot of it is pre-post. A lot of it is, I had some learners, we intervened, and now this is where they got. And so what are some of the ways to enhance the scholarly rigor when doing that type of intervention? You could consider a pre, a post, and a delayed post intervention, and that really looks at long-term retention. So that's a little bit different than just pre-post, teach someone and they learn. That delayed long-term retention can be a valuable call out, another way of looking at the sticking power of an intervention. Pre-post compared to historical controls can be a good way to do this. And you saw that a little bit in the X+Y intervention, right? That was just pre-post intervention, but that comparison sort of, broadly to that historical group was helpful. Pre-post that really looks comprehensively at not just the impact on knowledge or the impact on skills, but also the impact on attitudes or behavior changes can be a good way to triangulate the impact of an educational intervention in a way that becomes educationally impactful or meaningful. So the behavior change, that holistic view of the intervention, can make that pre-post design more attractive to readers and reviewers. It's hard to do single institution studies that are relevant for educators broadly, but there's some ways to think about how to reach just a little bit farther at your single institution. So could you take a patient-centered approach and include multiple different professions? Let's say you want to teach about stroke. Is there a way to bring in PT and OT and speech therapy and social work, right? All the people, all the professions that take care of that patient and show how it influences them. Or study something in the EMU and bring in the technologists, the technicians that are in the EMU and teach all throughout that unit. Is a very patient-centered approach to a single institution that can be relevant more broadly outside of a single institution's context. Can you study this in multiple disciplines? Take an education-centered approach. So all residents need to know how to take care of stroke patients. So we could teach neuro and ED and IM and anesthesia all at the same time, and looking at the variability of that educational intervention across those residents and residency training programs can add power statistically and also educationally. And can you gain understanding from a single institution study? So this is not just what happened, but qualitative data may help to understand how that happened or why the learning occurred, which can help to create context for other educators that may consider the intervention at their institution. So be rigorous. Don't submit a pilot study. Don't submit a trend analysis. And don't publish on being first. Being first isn't always impactful. Doing impactful work is what is impactful. It may be that this is the first time someone's done something because it's not the right first thing to do. And others have thought about and gone in a different direction. So we really like to see articles that published important work, not necessarily first work. Number 4 tip, jump in. So be a peer reviewer, sign up to peer review, or write a blog, a commentary, a work in progress, or a hot topic. The Neurology Education blog is a great way to just start to get involved in the conversation. Be an abstract writer or an abstract reviewer. Join a journal club. The A.B. Baker section is starting back up, their Neurology Education Journal Club. So jump into the conversation that way. Or write a research, a non-research paper, a review paper, a methods paper, or a viewpoint. And then lastly, we'd love to see you publish your curricula. You're doing that work at GW or maybe wherever you are. And we'd love to see those off-the-shelf curriculum that can help other educators not reinvent the wheel. And take a look at the curriculum resource repository, not only for a way to be an author, but perhaps a way to make the teaching kind of easier in your area. So with that, happy to take any questions. I'm going to pull up the CME slide. So for those that want CME, and happy to take any questions with the time that we have left. Thanks so much for joining.
Thank you so much. That was really great. That was very helpful. I see some questions in the chat. So I guess I'll start with those. So the first one is, should residents be exposed to outpatient clinical practice early in their training, for example, by continuing to follow patients for whom they were responsible during hospitalization?
It's a great question. And I guess you're asking for my opinion. So I'll give you my opinion. I think absolutely. And I think many of us would agree that early exposure is so critical for everyone, for residents and for students, across the field. The challenge is how to do that. Neurology is increasingly subspecialized into many of these ambulatory areas, and it's just hard to do. So one of the things I think that a lot that we've been talking about a lot as a journal is not how to increase the quantity of exposure residents have, but the quality of the encounters, of the visits, of the kind of patient care that they're doing. So how can we make one clinic in the neurobehavioral space or the neuro-oncology space really impactful so that the residents can see what is it really like to be a neuro-oncologist? What is it really like, to take care of those patients? And that longitudinal piece is nice. That patient-centered noon conference was a really neat way of doing that. So it took an existing conference that already exists, that is not extra time, and shed a completely different light on what it's like to be a neurologist, what it's like to see a patient over time, what it's like to really take care of someone in that way. So I think as educators, what we want to do is not think about how to increase what is needed for residents and increase the number of rotations here or blocks there, but how do we use the things that we're already doing to create more impactful educational events in both the inpatient, but definitely the outpatient space.
The next question, or more a comment. It's interesting to note that the authors of the Harvard program are also the principals in the Neurohumanities Network. They're particularly interested in applying the principles of narrative medicine to neurology.
Jonathan, I love you brought up neurohumanities. So we had a call in for those that are going to go to the annual meeting there's an education room at the annual meeting that offers CME content throughout the 5 days of the meeting around education. And this past year, we had a call for new neurohumanities submissions. And we got, I think, over 12 of the 60 submissions to the room this year were courses on neurohumanities. So I love the group at Harvard. They're great, but there's a lot of educators all over the country and really internationally that are really interested in looking at how do we teach neurology through the humanities and how do we teach humanities within neurology, right? Both of those things are happening. How can we go to an art museum and look at some paintings and understand clinical reasoning and differences in perspectives, right? It's really fascinating to all look at the same painting and realize that we're seeing slightly different things. Turns out we're all looking at the same patient oftentimes, and the internal medicine group is seeing one thing and the neurologists are seeing another, and the ER doc is seeing something that's slightly different. And we all kind of, bemoan each other for not seeing what we see. And why did they get sent this consult, or why am I asked to do this? But it's that difference in perspective. And so actually going to an art museum may be the best way to understand how to go see a consult in the ER. And so that humanities approach to training is a really interesting area. Plus, it's really fun to go have a glass of wine and walk through the art, museum and learn and kind of change the way that we're thinking. So I think there's some real innovations that we have a chance to see in the journal and in the field of sort of different ways to teach and learn, and humanities is definitely one of those.
Yeah, definitely. And since you mentioned it, for anyone who has not been to the neurology education room a day, and highly recommended, I think it's been really helpful for me in my practice. I've learned so much from the talks and from the people there. Okay, so the last question we have in the chat is, how is AI changing the landscape of graduate medical education?
I love this question. I mean, this is unknown. It's AI is changing everything that we do, and it certainly is going to influence education and graduate medical education. So we could spend an hour sort of talking about this. The one thing I'll call out that I think is kind of most interesting to me, because there's a lot of ways people are using AI. They're using it to evaluate charts, to reflect charts back to residents so you can see the types of patients that you're seeing. So then you know what lectures to give as a part of noon conference, right? They're using AI to make seeing the patient easier and kind of help support note writing. And some people think, well, that's going to take away the skill of developing the ability to reason through a case. And others think, well, actually frees time, going back to psychological safety, for residents to actually focus on this. One thing that I'm most excited about is AI's ability to provide feedback in a different way. Think about how much happens in a clinic room that could be used as feedback to residents, to faculty, to the CCC committees that we just haven't been able to capture. And some of the ambient listening devices, in addition to listening to how to write your note and how to understand what's happening with the patient, could be an interesting feedback mechanism in both undergraduate and graduate medical education to help residents sort of understand some of those opportunities to approach the conversation differently, a counseling piece differently, an opportunity to sort of mention a side effect in a way that would stick with the patient. So there's just a ton of data. AI is simply a data tool. It's not anything different than that. And we've been using data tools for a long time to help to support education. What we've got to figure out to do is how to cull the data and present it back to educators and residents in a way that they can use it to enhance teaching. So this is a great place for innovations. Neurology Education, the journal, is really interested in AI papers, not just papers talking about what AI could do, but innovating in their space. I use this AI tool, because it's a tool, to solve this education problem. We all have got educational challenges and problems. And this is what I learned in doing that. And these are the outcomes that I assess. So those would be great things to submit to any journal. Certainly Neurology Education would love those. And that's very much where the field is. We've had a couple of viewpoints. We've had one, maybe two papers on AI that have either come out or will come out very soon. But we're very interested in this. This is going to be a part of the conversation for a while.
Right. I think that's all we had. We're going to put in the CME code in the chat again. We have a last question that came up here. I've noticed some differences among the students, trainees who were trained pre-post and during the COVID pandemic. It would be interesting to assess for any differences in learning and perspective. Wonderful talk. Thank you.
It's a great comment. This comment is is we could have a whole hour long talk about this, right? So the best research studies start with an observation. And it's either a patient observation or a clinical observation or an educational observation, right? But that's where research studies start. I saw a patient, this is what happened. Why did this happen? Let's take that to the lab. Let's take that to the MRI or functional MRI or the EEG, or let's study that from an education standpoint. So this is an observation. We love observations. You're seeing something out there. Like I'm seeing something different. I want to understand it. So what's the next step? Dive into the literature, right? Take a step back. And what are other people talking about? What is also being written about this? Next step, go to a mentor, talk with colleagues, take this to the next resident meeting. Like, what is everybody else observing about some of those changes in learners? We've all changed as a result of the pandemic. It has just changed life and reality. And as you do, you want to be taking that observation and forming it into a question. And there's about 60 different questions that could come out of this observation. How has the pandemic changed the way in which we communicate effectively? How has it changed the way that we learn asynchronously? Here we are on a Zoom call. No one did these things in 2019. How has it changed the way that we approach patient care, right? We're doing and those sorts of things, right? So this observation over time, kind of diving into the literature, reaching out to colleagues, getting advice from mentors, starts getting culled into a question, an education research question. And I love that you asked this, and maybe we end on this question because it's probably the most important way to take your project and move it into something publishable is ask a question that can be answered and that is relevant to others. The more time you spend on taking that observation and sort of molding it into a really crisp question, it could be studied in many different ways. You may use a qualitative study, asking a bunch of people how they learned before and after the pandemic and looking at some of the themes there. You may quantitate those. You may find a survey, something that's been done in internal medicine, and look at that in the neurology space and understand the neurological nuances of that, right? But the more clear that question is, the more likely that study is to inform what other people are talking about, to enter into a conversation and be publishable. So great question.
Great. I think that's all for the questions that we have. Thank you so much for your time and for this great talk. Really, I'm sure everyone, I know for myself, learned a lot from it.
Thank you. I'm glad the tech works. Sorry about the delayed
Yes.
start. Thanks. Right.
No problem.
All right.
Great.
See you, Alexander. Thanks so
See you
much.
at the end. Have a
Yep.
great
See you
rest of
there.
your day.
All right. Bye-bye.